Welcome to this deep dive, where we take the source materials you shared and really unpack a specific subject to give you a richer understanding.
Glad to be here.
Today we're tackling lower extremity amputations, drawing primarily from the authoritative textbook, Rutherford's Vascular Surgery and Endovascular Therapy. Think of this as your shortcut to grasping the key aspects of this major surgical field.
It's a field built on centuries of progress, really. If you think back, amputation used to be just a terrifying prospect, patients facing overwhelming blood loss, infection, agony. It's quite a journey to see how it has evolved.
Absolutely. And the textbook highlights some true pioneers. Take Ambroise Paré, that innovative barber surgeon from France. Before him, surgeons used boiling oil to stop bleeding. Can you even imagine?
He sounds brutal.
Totally. Paré's introduction of vessel ligatures was such a game changer, a much more controlled way to manage hemorrhage.
Definitely.
And then, fast forward to the 19th century, Joseph Lister's work on antisepsis fundamentally altered surgery by drastically reducing those deadly postoperative infections.
Yeah, Paré's move wasn't just technical. It shifted surgery from something frantic and hurried to a more considered procedure.
Exactly. Their work really provided the foundation for amputation to become less of a desperate last resort and more of a refined surgical option aimed at improving a patient's well-being and, crucially, their survival in many cases.
That's right.
So our goal today is to dissect the core principles guiding amputation surgery, explore the various levels from a single toe right up to a hip disarticulation, and discuss the different techniques and also what we generally see in terms of outcomes. We want to equip you with a clear and insightful understanding of this complex area without getting lost in excessive medical jargon. Okay, let's dive in by looking at the fundamental goals of amputation surgery.
Right. So the primary objectives, they really revolve around setting the stage for the best possible healing and future function. This means ensuring there's adequate blood supply remaining in the limb, having enough healthy soft tissue to cover the bone, and preserving as much of the natural bony structure as possible. These are kind of the essential elements our source lays out.
That makes intuitive sense.
Yeah.
You need a solid biological foundation to enable healing and prosthetic use later on. The text also emphasizes the need for a gentle, atraumatic surgical approach, avoiding instruments that could crush tissues.
Absolutely.
It sounds like minimizing additional injury during the procedure is paramount, especially given the often compromised state of these patients.
Precisely. And while there isn't one single best way to control bleeding during surgery that everyone agrees on, there are some, let's say, established best practices.
Like what?
Well, the textbook advises against making skin incisions with a bevel, highlights the importance of keeping the skin attached to the tissues underneath it,
Right.
and stresses that any skin flaps created should not be under tension. If those flaps are stretched too tight, their blood supply can be compromised, hindering healing.
Now, my gut feeling might be that a longer remaining limb is always better, and the source does confirm that a longer stump is generally preferred for better prosthetic fitting and, how the body moves afterwards.
True.
But there's a really important trade-off here, isn't there? Length shouldn't come at the expense of healthy tissue.
That's a crucial balance to strike, absolutely. Leaving behind tissue that isn't getting enough blood or is infected, even if it results in a longer stump, will ultimately just lead to more complications.
Makes sense.
And similarly, while we need good soft tissue coverage for the bone, too much bulk can also make it difficult to fit a prosthesis correctly. The focus has to be on healthy, viable tissue, not just maximizing length or size.
Here's where it gets really interesting. The source discusses stabilizing antagonistic muscle groups. I wouldn't have intuitively thought about that. What's the thinking there?
Well, what's fascinating here is how it attempts to recreate the natural muscle balance. When a limb is amputated, you disrupt the natural pull of opposing muscle groups. So by stabilizing these through techniques like myoplasty, where muscles are sewn together, or myodesis, where muscle or tendon is attached directly to the bone, you help maintain better alignment of the remaining skeleton.
So it's not just about strength.
Not just strength, it's also about proprioception, that sense of where your limb is in space, which is crucial for prosthetic control and a more natural way of walking. The source also cautions against excessive stripping of the periosteum, that's the membrane covering the bone.
Right, the one important for blood supply.
Exactly. Stripping too much can increase the risk of complications.
And what happens when infection is already a significant problem? That must really complicate the surgical approach.
It certainly does. When there's significant infection, the immediate priority becomes controlling it. The textbook talks about using physical barriers, trying to wall off infected areas.
Okay.
In very severe cases, a procedure called a guillotine amputation might be necessary as a first step. It basically removes the heavily infected tissue, allows for drainage. It's an open amputation.
So not the final step then.
Often not. A two-stage approach is common. First, the guillotine amp to deal with the infection. Then, once the patient's more stable and the infection's under control, a second surgery to create the final amputation. And of course, antibiotics, chosen based on the specific bacteria, are critical.
Right. Once the amputation surgery is complete, what does the immediate post-operative care typically involve?
Right after surgery, protecting the amputation site from further injury is the main concern, usually done with either a rigid or a soft dressing.
Okay.
The source emphasizes that the incision needs to heal well before the patient can start putting weight on it. And because these patients often have reduced mobility, they're at a higher risk of DVT, deep vein thrombosis.
Wally plots.
Exactly. So preventative measures, DVT prophylaxis, are essential.
Yes.
Medication, compression devices, that sort of thing.
Makes sense.
The textbook also recommends antibiotics just before and after surgery to help prevent wound infections. And interestingly, it advises against trying to overly sculpt the wound for cosmetic reasons.
Really? Why is that?
It can actually interfere with how well it heals. Function over form, initially.
Box 115.1 in our source seems to be a really helpful summary of all these core principles. It really lays out all the different factors a surgeon has to consider.
Yeah.
From making sure there's enough blood flow to avoiding those unnecessary cosmetic procedures.
Exactly. It serves as a really useful checklist, highlights just how complex amputation surgery is, all the things contributing to a successful outcome.
Okay, so we've laid the groundwork with the general principles. Now let's move on to explore the different levels at which amputations can be performed and the specific techniques involved. We'll start distally, right, at the end of the limb, with toes and rays.
Right. The foot has a really intricate anatomy, as our source shows. Tarsals in the midfoot, hindfoot, metatarsals in the forefoot, then the phalanges for the toes. Big toe has 2, others have 3.
Okay.
For toe amputations, typically for problems affecting the middle or end of a toe, a racket incision is often used. Gives that distinctive shape, like a tennis racket.
Yeah, I see.
Which helps get a tension-free closure. The handle runs lengthwise along the top. Position varies slightly depending on the toe.
And the technique itself involves dividing tendons at the same level as the skin incision, trimming the bone. If it's a disarticulation through the joint, the cartilage is removed.
Correct. Cartilage removed, sharp bone edges smoothed down. The source specifically advises against using excessive electrocautery, that heat tool, and recommends closing in a single layer with interrupted, non-absorbable sutures.
Okay. And moving beyond just one toe, a ray amputation. That's the toe plus its metatarsal bone.
Yes, removes the digit and a portion of its associated metatarsal. Again, a racket incision can work here. During a ray amputation, it's really important to be careful to avoid damaging the digital arteries and nerves running alongside.
The textbook also points out some important potential consequences. Apparently, removing both the first and second rays can significantly alter gait, how someone walks.
Yeah, it can have a noticeable impact. And an isolated amputation of the first ray, the big toe and its metatarsal, has a relatively high risk of the problem coming back, like recurrent ulceration.
Interesting. So some surgeons might even consider a full transmetatarsal amputation in that case.
Some might, although the evidence isn't totally conclusive. It really highlights the interconnectedness of foot mechanics, doesn't it?
It really does. A seemingly small procedure can have broader effects on weight distribution, walking, potentially causing more issues later.
Exactly.
Let's move a bit further up the foot then to the transmetatarsal amputation, or TMA. This is across all 5 metatarsals.
Yes. A TMA is a good option when the whole forefoot is affected, or maybe when multiple ray amputations might otherwise be needed.
And the benefit.
A significant benefit of a successful TMA is that it often allows patients to continue wearing standard footwear and walk with a gait that's, pretty close to normal.
But not always the right choice.
Right. It's not ideal if there is a significant bony deformity in the midfoot or hindfoot. That could lead to instability, balance problems.
And the technique for a TMA involves incisions on the top and bottom of the foot.
Yes, dorsal and plantar incisions across the foot. Extensor tendons on top are divided. Metatarsal bones are cut typically shorter towards the outside with a bevel on the plantar side.
Okay.
And then the attachments of the plantar fascia, that thick band on the bottom, and muscles to the metatarsal heads are released.
The source also mentions potentially lengthening the Achilles tendon.
Yes, some surgeons recommend lengthening or even cutting the Achilles tendon at the back of the ankle. This helps reduce the risk of what's called equinus deformity, where the foot tends to point downwards.
Ah, because the amputation disrupts the muscle balance.
Exactly. Addressing the Achilles helps ensure a more neutral foot position, which is really important for walking and preventing future skin breakdown.
That's a key point. Okay, now we're moving into the midfoot and hindfoot amputations. The Lisfranc, Chopart, and Simon procedures. These sound less common.
They are indeed less common. The textbook notes that if a TMA isn't feasible or fails, many surgeons would actually choose a transtibial or below-knee amputation instead.
But these still have a place.
In certain specific situations, yes, these more proximal foot amputations can still be valuable options. The hindfoot ones, like Boyd and Piragoff, are even rarer, mainly used in children to try and preserve leg length for growth.
Let's break these down, starting with the Lisfranc amputation.
Okay. The Lisfranc amputation involves disarticulation separation at the joint right at the tarsometatarsal joints, basically separating the forefoot from the midfoot.
How's it done?
The textbook describes making a long incision on the plantar side, the bottom, to create a flap. Interestingly, it mentions a modification by Sanders that aims to reduce the risk of the foot turning inward equinovarus deformity
How's that work?
by keeping the base of the fifth metatarsal bone and the attachment of the peroneus brevis tendon. Releasing the Achilles tendon is also typically done here.
Got it. Next up is the Chopart amputation.
The Chopart is even more proximal, further up than the Lisfranc. It involves amputation through the telecalcaneonavicular and calcaneocuboid joints. Essentially leaves behind just the talus and calcaneus ankle and heel bones.
Similar technique?
Similar in that it involves creating a long plantar flap. Cutting the Achilles tendon, an Achilles tenectomy, is generally recommended. There's even mention of potentially reattaching some remaining tendons to try and improve function.
There must be some significant things to consider after surgery with these midfoot amputations, given how much of the foot is removed.
Absolutely. Because both Lisfranc and Chopart amputations significantly alter the normal way the foot functions during walking, their long-term success can be, well, somewhat limited.
What happens post-op?
After surgery, a short leg cast is usually applied, carefully molded to keep the remaining bones in the right position relative to the lower leg. Weight bearing is typically delayed for several weeks for healing.
And long-term?
Patients with a Lisfranc might just need a shoe filler, while those with a Chopart often need a custom ankle-foot orthosis, a brace for support.
Okay. Now for the Syme amputation. This one sounds quite different.
It is. The Syme amputation is performed right at the level of the ankle joint. The textbook describes incisions front and back around the malleoli, those bony ankle bumps.
And the process.
Tendons around the ankle are divided, the dorsalis pedis artery is tied off, ankle joint capsule opened. A really key part is carefully dissecting the heel fat pad.
Why is that so important?
The surgeon has to stay very close to the bone to avoid damaging this pad because it's used to create a weight-bearing surface. The foot is then disarticulated from the lower leg.
And the malleoli.
That's a unique aspect. The malleoli can either be divided and the heel pad secured in one operation, or their removal can be delayed to a second stage. The goal is a stable, weight-bearing end using the patient's own heel pad. Some surgeons even drill small holes in the tibia and fibula to help secure it.
What are the main advantages and disadvantages of a Syme?
The big advantage is preserving significant leg length. Allows patients to put some weight on the end, maybe for short transfers, without a prosthesis.
Yeah.
Usually a slight leg length difference compared to the other side, which can affect other joints. Also, the prosthesis for a Syme tends to be a bit bulkier around the ankle, maybe less cosmetically appealing than a standard below-knee one.
Okay, now we're moving up the leg to the transtibial or below-knee amputation, the BKA.
Yeah.
The source notes there's significant variation in surgical techniques here. Why is that?
That's largely because there isn't one single universally agreed upon technique proven superior to all others, in terms of healing, function, long-term comfort.
So things vary.
Yeah, factors like the type of incision, how much tibia and fibula are preserved, how muscles and nerves are handled, they can all vary quite a bit. The leg itself has 4 main muscle compartments, major arteries and nerves running through. A really important principle the source emphasizes is avoiding separating skin and soft tissues from the underlying muscle. Many flap techniques rely on the blood supply through those connections.
The textbook describes several flap types. The posterior flag technique, often linked with Burgess, is highlighted as most common for vascular surgeons. What makes it popular?
It's favored because the blood supply to the calf muscles, particularly the gastrocnemius at the back through the sural arteries, is often quite good even when the main popliteal artery is blocked.
Makes sense.
Mm.
Is there a standard length?
There's a general guideline for minimum tibial length to optimize prosthetic function, usually around 12 to 15 centimeters from the tibial tuberosity, that bump at the top.
And the flap design.
The posterior flap is often designed to be about 2/3 of the leg circumference, with the shorter anterior flap about 1/3.
Can you walk us through the technique briefly?
Sure. It involves cutting skin and fascia, dividing muscles in front and side, cutting the tibia and fibula at slightly different levels, then creating the posterior muscle flap with a knife. Major blood vessels are tied off, nerves are carefully cut sharply and allowed to retract. The posterior flap muscle is trimmed but left somewhat bulky for cushioning.
Any bone shaping?
Often the front of the tibia is beveled, rounded off. Some surgeons do a myodesis of the gastrocnemius, attaching it to the bone for balance. Then irrigation and closure.
The source also briefly touches on other flaps, sagittal, skew, fishmouth, medial. Are these just alternatives?
Pretty much. They might be used in specific situations where a long posterior flap isn't possible or maybe isn't the best choice for that particular patient.
And then there's the Ertl procedure that sounds more involved.
The Ertl procedure is indeed more complex. Surgeons try to create a bony bridge between the tibia and fibula using a piece of the fibula as a graft.
What's the idea behind that?
The idea is it might provide a more stable end, allow better force transfer to the prosthesis, potentially making walking more comfortable, more efficient.
Right.
But it's technically demanding, takes longer, needs non-weight-bearing time for the graft to heal, and the textbook points out whether it's truly superior to traditional BKA hasn't been definitively proven, though some studies suggest benefits for some.
And we can't overlook those urgent situations. Guillotine amputation again for severe infection? And cryoamputation using extreme cold. That sounds unusual.
Cryoamputation is very specific, less common, typically reserved for patients too ill for general anesthesia.
How does it work?
In cases of severe gangrene or very poor blood flow, dry ice is packed around the limb, often with a tourniquet above, to essentially isolate it, prevent toxins spreading. Once the patient's stable enough for surgery, a formal surgical amputation follows.
Any benefits?
Some studies suggest maybe improved survival in very frail elderly patients, but it has potential complications like the frost line migrating and high likelihood of needing more surgery later.
What are some key things to manage carefully after a BKA?
One significant concern is the tendency to develop a knee flexion contracture. Pain makes patients keep the knee bent, and it can tighten up, making it hard to straighten.
How is that prevented?
Some surgeons use a knee immobilizer, a brace to keep it straight, though not universal. Early, consistent exercise programs are really crucial for range of motion at knee and hip. The textbook also points out that initial wound healing isn't always perfect. A significant percentage, maybe 20% according to some studies, may eventually need a higher level amputation.
Okay. Moving further about the leg, we have the through-knee amputation. What's the main rationale for choosing this level?
A through knee removes the lower leg tibia, fibula, and the cartilage surface at the end of the thigh bone, the distal femur, leaving the femur intact.
Who is it good for?
Can be a good option for patients with potential for good rehab, but who aren't suitable for a BKA, maybe due to their vascular disease level. Interestingly, studies show through knee patients often have higher rates of successful walking with a prosthesis compared to above knee amputees.
Any specific techniques mentioned?
Yeah, the textbook mentions the Mazet technique, where femoral condyles, the bony bumps, are preserved and shaped, and the modified gritty Stokes, which involves cutting the patella, the kneecap, and fixing it to the femur end.
The surgical technique generally involves a fishmouth incision.
Typically, yes. Then dividing ligaments, detaching the patellar ligament, carefully dissecting and removing the joint capsule. Cruciate ligaments inside are divided, vessels tied off, nerves cut, remaining muscles divided.
And the goal for the end result?
The goal, like other amps, is a stable end for weight-bearing and prosthetic use. Here, it involves removing menisci, shaping femoral condyles. Hamstrings are attached to the patellar ligament, incorporating cruciate remnants, then layered closure. That's right, creating a functional weight-bearing stump right at the knee joint level.
Now we arrive at the transfemoral or above knee amputation, the AKA. This is a more significant surgery.
It is. An AKA involves amputation through the thigh bone, the femur. The thigh has 3 main muscle groups. Femur is usually divided somewhere between middle and lower third.
Incision type.
A common type is a fishmouth incision with equal length flaps front and back. Though the orientation can vary based on surgeon preference or circumstance, Major femoral vessels are ligated, thigh muscles divided, sciatic nerve carefully stretched and cut.
The textbook mentions a tendency for the hip to flex and abduct, bend forward and move ad after, aka, because adductor muscles are detached.
That's right, the balance is disrupted. It describes a technique called myodesis, where small holes are drilled in the femur end, and key muscles like adductor magnus and quadriceps are anchored to the bone.
Why do that?
To try and stabilize these muscles, improve how the limb functions with the prosthesis. While the evidence proving long-term benefits of myodesis is still evolving, it's thought to be particularly helpful for patients more likely to walk with an above-knee prosthesis.
Any post-op specifics for AKA?
There's a somewhat higher risk of wound contamination, so initial dressings are typically left on longer than for a BKA. It's also really important to understand that walking with an AKA prosthesis requires significantly more energy than with a BKA, and successful long-term walking is less common, especially in older patients with vascular disease.
Finally, we have the hip disarticulation. Sounds like the most extensive lower extremity amputation possible.
It is. Hip disarticulation involves amputation right at the hip joint itself, removing the entire femur. The anatomy around the hip is very complex, many powerful muscles.
How's it approached?
The textbook describes different incisions, like an anterior racket shape or a long posterior flap. It involves very careful dissection and division of all muscles crossing the hip joint, plus tying off femoral vessels, cutting femoral and sciatic nerves.
It certainly sounds complex and extensive. The source mentions a myoplasty closure afterwards.
Yes, often some remaining hip muscles are sewn together for better stability and soft tissue coverage. And given how close the surgery is to the torso, increasing contamination risk, careful wound dressing is absolutely crucial.
What kind of dressings?
The textbook notes vacuum-assisted closure devices, wound vacs, or iodine-containing adhesive dressings can be particularly helpful for these more proximal amputations.
Exactly. Preventing infection and ensuring good healing are paramount after such a major surgery.
So, regardless of the specific level, what are some general principles of postoperative care that apply beyond just protecting the wound? Well, the textbook mentions that in their typical practice, initial surgical dressings are usually left in place for around 5 days, unless there's a specific reason to change them earlier, like excessive drainage or infectious signs.
What about immediate prostheses, IPOPs?
There's discussion about immediate postoperative prostheses, IPOPs, fitted right in the OR. Some believe they help with earlier mobility, reduce swelling.
But there are downsides.
Yeah, using IPOPs requires a highly skilled team. They're not available everywhere, and they make it hard to regularly check the wound early on. Regardless of dressing type, careful blood sugar management, especially in diabetics, and ensuring adequate nutrition are essential for proper healing.
Now let's talk about the inherent risks. What does the textbook tell us about operative mortality?
Well, the 30-day operative mortality rate for major lower extremity amputations, it can vary quite a bit, actually. Ranges from around 2% up to maybe 20% in contemporary practice.
And for minor amputations?
Significantly lower for those at or below the ankle, typically in the 2% to 4% range.
What usually leads to these amputations?
Most common underlying conditions are poor blood flow, ischemia, and diabetes. Interestingly, the most frequent causes of death shortly after amputation are heart complications, followed by serious infections like sepsis and lung infections like pneumonia.
Have things improved much over time?
The tough reality is, despite advancements in anesthesia and critical care, overall mortality rates after amputation haven't significantly changed in recent decades. Large-scale studies have identified a number of risk factors linked to higher death rates after both AKA and BKA.
Such as?
Things like being on hemodialysis for kidney failure, low platelet count, poor functional status before surgery, older age, congestive heart failure, sepsis. There are even weighted risk scores developed to help predict a patient's perioperative mortality risk. It's a sobering reminder of how serious these procedures are.
It certainly is. What about long-term survival for patients who undergo amputation?
The textbook indicates long-term survival is definitely influenced by the amputation level. Patients with BKAs generally have better long-term survival than those with AKAs.
Any other factors?
Patients with diabetes, and particularly those who also have kidney failure, tend to have poorer long-term survival rates. However, overall, there has been some improvement in long-term survival following major lower extremity amputation in recent years.
And what about functional outcomes? What can patients typically expect regarding moving around, living independently?
After toe, ray, or TMA amputations, the expectation is usually near normal gait with regular footwear. However, after a transtibial amputation for vascular disease, Well, unfortunately, walking with two legs using a prosthesis isn't a guarantee for everyone.
What do the numbers say?
Some reports suggest only about 25% of major lower extremity amputees can consistently walk with a prosthesis outside their home. It can be due to pain, residual limb problems, other medical issues.
Does rehab help?
Patients getting specialized rehab in an acute inpatient facility tend to have better functional outcomes, yes.
Are there predictors for who might struggle with a prosthesis?
Several factors present before surgery are linked to lower likelihood of successful prosthetic use. Things like being unable to walk before the amp, having an AKA, being primarily homebound before surgery, older age, dementia, end-stage renal disease, coronary artery disease.
What about older AKA patients?
Older individuals with a transfemoral amputation very rarely achieve successful walking with a prosthesis, and needing dialysis is a very strong predictor of not being able to walk after an amputation.
But can they maintain independence?
Despite limitations in using a prosthesis outside, the majority of patients are able to maintain their living situation at the same level as before. It's also really important to note that patient motivation and having adequate financial resources for rehab and prosthetics play a crucial role.
The source mentions Medicare K levels.
Yes. In the U.S., Medicare classifies a patient's functional potential into K levels. This determines the type of prosthesis eligible for reimbursement based on motivation and potential functional milestones.
Reamputation needing further amputation on the same or opposite leg must be a big concern.
It is indeed a significant concern. The textbook gives some concerning stats. For patients initially having a toe amputation, around 50% eventually need further amputations on either leg down the line.
Wow. And higher levels.
After a foot or ankle amputation, about 35% progress to needing a higher level amp within just 1 year. Even after a BKA, a notable percentage go on to require an AKA on the same leg or a major amp on the other leg within a certain time frame.
Is there a pattern?
Yes, there is an inverse relationship. The higher the first amputation, the lower the risk of needing another one above it on the same leg.
Does diabetes play a role?
Unfortunately, yes. Patients with diabetes are almost twice as likely to need reamputation compared to non-diabetics. The textbook gives specific rates for reamputation on the same leg at 1, 3, and 5 years for diabetic patients at different initial levels. It also highlights that complicated diabetes, renal failure, and an initial BKA are linked to higher risk of additional amputation-related procedures.
Finally, let's delve into potential complications after amputation. Sounds like both local site issues and systemic problems.
That's correct. Local complications include bleeding. Needing another surgery happens in a small percentage, maybe more likely with antiplatelet meds. Infection is a more significant risk.
How common?
Reported wound infection rates range from about 13% up to 40%. Risk factors include diabetes, pre-existing infection, poor nutrition, certain cancers, older age, lack of insurance, hematoma, prior bypass grafts. If synthetic graft material was used before, removing it might be needed if a deep infection develops.
How are infections treated?
Can range from simple antibiotics for superficial ones to more surgery for deeper infections. Contractures, joint stiffness, especially hip and knee, are another potential local issue. Knee contractures can really hinder prosthetic use.
Can they be fixed?
Significant ones can be challenging to correct, so prevention with rigid dressings, early exercise is important. Prone positioning lying on the stomach can help prevent hip flexion contractions.
Okay, what about systemic complications?
Yeah.
Affecting the whole body?
Yes, these can be serious. Cardiac events, particularly heart attack, are unfortunately the most common cause of death after amputation. Studies report cardiac complications around 10%, including arrhythmias, heart failure.
So careful monitoring is key.
Essential. Continuing antiplatelets, statins, ensuring good perfusion, vigilance for cardiac signs. Respiratory complications, like pneumonia, are also a risk. Given reduced mobility, there's a high risk of VTE, like DVT. Prophylactic low molecular weight heparin is usually very effective. Unfractionated heparin might be used sometimes.
Other systemic issues.
New onset kidney failure can occur. Stroke, while less common, can happen and is a cause of perioperative death. Psychiatric issues, including PTSD, can occur, especially after trauma combat amps, less common after vascular ones. Risk factors for major depression are prevalent, and the textbook mentions suicidal thoughts in vascular amp patients.
And pain seems like a huge issue.
Pain is very common long-term. Residual limb pain and phantom limb pain sensation from the missing part. It's important to figure out the cause. ongoing ischemia, musculoskeletal or nerve issues like neuromas, tangled nerve endings, or chronic infection.
What about phantom pain specifically?
True phantom pain is complex, variable incidence. Inadequate pain control post-op might play a role. Meds like gabapentin are sometimes used. Newer techniques like targeted muscle reinnervation, TMR redirecting severed nerves to nearby muscles, show promise for improving function and reducing pain. Overall, a comprehensive, multidisciplinary approach to pain management is crucial.
It's clear that while amputation can be life-saving and function-restoring, it carries significant risks and involves a long journey of recovery and adaptation. Looking towards the future, what directions does the textbook suggest for this field?
Well, the textbook acknowledges that a true biological replacement for an amputated limb or digit isn't yet a reality. But there's a lot of exciting research. AI is being explored to potentially help predict the best amputation level. Prosthetic tech is continuously improving more sophisticated, intuitive devices. Techniques like TMR are gaining wider adoption. The authors suggest we might be moving towards a future where different disciplines, medicine, engineering, work together more closely for functional limb restoration.
So, to bring our deep dive to a close, lower extremity amputation is clearly a surgical procedure with a long history and a vast array of factors to consider. It's far more than just the operation.
Absolutely.
It involves understanding the underlying conditions, thoughtful selection of level and technique, meticulous post-op care, and long-term outcomes. It truly highlights the intricate interplay between surgical skill, biomechanics, the patient's overall health, and their rehab potential.
It's a very intricate decision-making process, absolutely. A multitude of factors need to be carefully weighed for each and every patient to get the best possible outcome.
And on that note, here's a final provocative thought for you to consider. Looking beyond the immediate surgical and recovery aspects we've discussed, what broader societal considerations come into play with lower extremity amputation? How does this procedure impact a person's identity, their sense of self, their place in the community, and how can we as a society better support individuals navigating the challenges and triumphs of life after amputation? That's something to continue to think about long after this deep dive concludes.